man, you see the instrument, the scapula that he has invented. And he did numerous experiments on slaves without anesthesia. And we're using some of that knowledge today. And Annika was subjected to 30 experimental surgeries. And this is such a sanitized picture of what happened. But that's what we have in the history books. But you can imagine it looked nothing like this. In 2018, Dr. Sim's statue was removed from New York City. It was across from Central Park. And because of how his experiments had been done and the abuse that he gave to the slaves, he no longer is revered to the way he has. I understand there were 3 statues of him in the country and 1 was removed. Moving into the 20th century, I'm sure you know that University of Vermont we have our own history. There was the eugenics movement in the early to mid 20th century. And in Vermont, eugenics measures applied to those Vermonters who compromised the quality of life in Vermont. And so what happened is that there were public health services, there were social services to assist the disabled, the ill, the poor, and it often included eugenic sterilization, and much of this was without consent. It wasn't only in Vermont. You may have heard of a civil rights activist, Fannie Lou Hamer, and she called it the Mississippi appendectomy. This happened to her as a teenager, the sterilization without her consent. Vermont approved a sterilization law in March of 1931. There were 253 sterilizations in Vermont. We were the 25th highest in the nation. About 2/3 of those sterilizations were performed on women. And 80% of the people were termed mentally deficient. The last sterilization was in 1957. Why can't I say this? I'm nervous. The Abenaki, thank you, was a group. Well, no, I say this all the time. Abenaki was a group that were subjects of the Vermont eugenics program, and approximately 3,400 Native American women were sterilized without proper consent. And there were the 3 Ds that targeted families and individuals: delinquents, dependency, and mental deficiencies. And so that's their terminology. But who were really targeted were the poor, the disabled, French Canadians, and Native Americans. Women were targeted more than men. To bring it home to UVM, Henry Perkins was a professor of zoology. And he was here from 1902 to 1945. And he led the way for the Vermont eugenics program. It's called the Vermont Eugenics Survey. And there were courses that were taught by Dr. Perkins and by Paul Moody in the 60s and 70s. And so this is the eugenics survey. But in 2019, then President Tom Sullivan apologized for UVM's role in the eugenics experiment. He calls it an unethical and regrettable part of the university's history. So very often you learned that people of color have a distrust, a mistrust of the medical system. And lots of times we wonder, or we know where that comes from. It was lots of it from experimentation without consent. Lots of it comes from just the interactions that you have. I tell this is just so recent, like a couple of months ago, I was at the dentist. And you know it's a microaggression because I can't move past it. And when I describe it, it's so minor, it's so silly, except she angered me. She gave me this talk about the importance of using a water pick It went on a little bit long. And then at the end of it, she said, "Do you know what a water pick is?" I was like, "Do I know what a water pick is?" I thought, I want to go, hell yeah, I know what a water pick is. So that sounds just so nothing. But I took it very personally. Like perhaps I don't know what a water pick is, and there may be people. I told my cousin, she said, "Well, there are people who don't know." I said, "Don't go there." So there have been gaps in care. And cardiovascular disorders, and lots of you know this, affects people of all demographics. But we are finding some race-based disparities in cardiac outcomes that are rather pervasive. The literature shows that physicians' decision about whether to refer patients for chest pain, for cardiac catheterization, can be affected by race and by sex. The lowest rates of cardiovascular procedures are provided to Black women. But heart disease and heart attacks is the leading death of Black women. Compared to men and whites, women and racial minorities and ethnic minorities very often receive inappropriate medical care or not as advanced medical care, and we're less likely to be involved in clinical trials, and I'll talk about that later. But in terms of racial and ethnic minorities, we receive less than 40% of the advanced heart failure therapies, heart transplants, and ventricular assist devices. And I know you all know all this. Women receive less than 25% of advanced heart therapy, heart failure therapies. And African Americans, this one is in the literature, and it's just odd to me. African American, all of this odd, but African American men have the lowest likelihood of receiving care from a cardiologist once they're in ICU. So something to think about. There's also infant mortality. And this has been a public health, a medical, a clinical issue for decades. And it's gotten better. Our rate of infant mortality has dropped, but not enough for African Americans. And the highest prevalence of infant mortality is in the state of Mississippi. I moved here from Memphis, and infant mortality is rather high in Memphis. And there's not just one infant cemetery. There are two infant cemeteries in Memphis, and there's a moving documentary on that. And one of the admins in my college there, we were looking at the documentary, and at the end, he walked up to me and said, "My sister is in one of those cemeteries," you know, so it just brings it home. 1,400 Black newborns die in the hospital each year, and we call this the mortality penalty. And within the past 10 years, we've been learning that Black newborns are more than twice as likely, and I know you've learned this statistic, to die in the hospital as white newborns. That's the mortality penalty that Black newborns experience. The mortality rate is twice as high for Black babies when they are cared for by a white physician. And Black babies' mortality is halved when they're cared for by Black physicians. I hope I said that right. White newborns, it doesn't matter if the physician is white or Black. But for Black newborns, the survival rate is better when they are treated by Black physicians. And this study was reported in 2000. And I will share with you, I may be alive today because of this dynamic. I'll give my birth year since I'm leaving. You won't have to. I was born in 1949 in a southern city, but there was the wonderful opportunity of a major white hospital and a major Black hospital. There was Duke Hospital and Lincoln Hospital. I was premature. I weighed 4 pounds at birth in 1949, and then lost weight and went down to 3 and stayed there. My mother said every time the nurse came into her room, she thought she was coming to say I had died. When I learned this statistic, I said, thank God I was at Lincoln Hospital. My rates were advantaged, according to the statistics, than if I had been to Duke Hospital. So let's talk about microaggressions and macroaggressions and bias. Um, Microaggressions was coined in 1978 by Dr. Chester Pierce, a psychiatrist at Harvard University. And he talked about the cumulative burden of repeated microaggression indignities that individuals experience. It affects your self-confidence. It affects your health. Dr. Pierce said that then. He was only talking about racial microaggressions, but we now realize that it transcends a lot of identities. And microaggressions occur every day. You've seen the phrase, or you may have seen the video of it's like 1,000 mosquitoes, like mosquito bites every day. I usually show that video, but I don't have time. And some people say it's like 1,000 cuts. You're right, 1,000 paper cuts, but it's pervasive and it's all the time. The micro part means that it's interpersonal. The aggression is self-explanatory. The behavior is harmful. And so microaggressions are not small. So I don't like when people say it's because they're small. No, they're not small. It's interpersonal. They're not harmless and they're not benign at all. And they hurt, they assault, they invalidate, and they insult. Daryl Sue is the guru of microaggressions. And he says that this happens primarily to marginalized people in our society. And he talked about 4 types of microaggressions. There are micro assaults. Here's an example that did not happen to me, but I started college at a predominantly white university, realized it was not for me, and I transferred to Hampton, thank goodness. And so an African-American student finds an N on her door, on her dorm door. That's a micro assault. Healthcare professionals refusing to accommodate patients with disabilities in the waiting room. So micro assaults attack the group identity of a person. And you often read that microaggressions are unconscious. We begin to think that micro assaults are conscious in the body of microaggressions. That micro assaults are conscious. They're deliberate, and the assaulter can get away with it, like putting that in on my friend's door. It shows that no one saw me do this. So there's some protection about that. Or you do that among people who have the same feeling as you. So you again are protected. There are micro insults. And as an example, really ridiculing international students' accent or pronunciation. An Asian American woman is seeking prenatal care from her doctor. She's got some concerns, some questions she wants to ask. And the doctor says to her, your English is great. Where did you say you're from again? This is an American citizen, American woman. And so that throws her completely off. When you experience a microaggression, one of the reasons that it is psychologically and cognitively demanding of you is that you instantly have to go through all of these gyrations. Because the first thing is, like someone says, where are you from? The first thought is, did I hear that right? And you go, was that racist? And you go, well, maybe it wasn't. So you're trying to figure out, so that takes some mental energy. And then you move to, so what are they trying to say about me, that I don't belong here or I don't look like them? All this is going through your mind. And then you go, well, I guess they don't like me or respect me. And then it goes through your mind, should I say something? Or if I say something, what will happen? Or would I just ignore it? All of that goes through your mind. And if you have to do this mental exercise, this psychological exercise every day, several times a day, depending upon your setting, it is exhausting, absolutely exhausting. And so these are micro insults. Another category, micro invalidations. And people feel as though these are the most serious of the microaggressions because They nullify your thoughts. They are uh, invalidating who you are. And so one of the most famous ones is saying, you know, I don't see color. That's what the last thing I want to hear, because that means you don't see me. Um, and oh, number two really drives me crazy. When you were, you know, when people were promoting uh, Black Lives Matter, all lives matter. Of course, all lives matter, but that's like negating the experience that Blacks were talking about, and we all know about that. An attendee being told, an attendee telling a female resident, oh, you're just too sensitive. And then again, not accommodating patients with disabilities. My daughter has multiple sclerosis and she spends hours in waiting rooms. And she has learned that she brings a pillow because the chairs and the benches are just so difficult to sit in. And if she asks for a different kind of chair, people look at her like, really? And so invalidating the experience and the needs that she has. Environmental microaggressions do happen, and social media. And that's what we hear so much about, the bullying that happens on social media. Those are an example of environmental microaggressions. Bullying means a whole lot of microaggressions. And so there's very little difference between microaggressions and bullying. Um, when we look at microaggressions in med school, you may not be able to see this, but let me see what I can do to help us. There are, from this article from the Journal of the National Medical Association in 2020, they had a study of the URM, as you know, means underrepresented minorities, and then people that were non-URM. So the first column of numbers are non-underrepresented minorities. The second column are underrepresented minorities. And there are two, this is a list of microaggressions. There are two where the URM is greater than the non, I hope I wrote that down correctly, than the non-URM. That doesn't make sense. Let me see. Oh, sorry, I'm looking at the wrong page of my notes. There's one where they're equal. And let me see if I can find that one. It says that microaggressions make me question my ability to be a successful physician. This is one where they're pretty much equal. One that the non-URMs are greater than the URMs is the last one. I have adequate resources to address microaggressions. It was higher there. And one that I think is very interesting, and that is, let me make sure, I feel comfortable. Where is that one? Two above, right where I was. Yeah, that's it. Thank you. I feel comfortable addressing the microaggressions that I experience. It was close. Um, so I think that's telling. I think it's another one up there. And this is where the URMs have higher scores than the non, and it's for most of these. The very first one, I'm mistaken for a service worker. That's okay. I mean, that's not okay. I mean, that happens. And when I do it, I feel terrible. Like you're in the store and I go, do you work here? And the person just looks at me because how many times has that happened to me? You know, so we have to be so careful. Um, this is what I hear students talk about so much, offended by comments made in the classroom about people of color. And we see there's a difference there. And then what lots of students talk about is this next one. BIPOC students really hate being asked to serve as a spokesman for their race. And you see a huge difference there. And I thought this one about witnessing, if you see the witnessing, I thought this was fascinating. Witness other students experiencing microaggressions. They're happening, but the underrepresented minority students see it more clearer than the non-students, the non-minority students. So I thought that that was an interesting chart. And the microaggressions, another study in the, this is the Journal of General and Internal Medicine, the type of aggressions that are experienced, what are the attributes? There's gender, followed by race, followed by age, skin color, and ancestry seem to come in together. There's height, that one surprised me. Socioeconomic status, clothing, sexual orientation, and weight. Those are the rankings in this study of microaggressions that occur in medical school. Because they're tall or short, they're shorter.
Somebody walks in the room is 6 foot, and our culture tells us they know everything. They know everything. And this is when we just have to be mindful.
That is so true. After we came out of COVID, when I met people, people said, I thought you were tall. That surprised me. I do have a self-image of being svelte, but I have never had a self-image of being tall. And so I was just so surprised about that. So I guess, Rebecca, they were disappointed. This is something that we're learning more about, microaggressions against healthcare providers. Over at UVM Medical Center, there's a white paper or a document, about this, that patients and their families can be very rude. There are people that have gotten broken bones from being assaulted by patients or their families. There are so many reasons we need to look at this. I've had some of my nursing students tell me when they experience a microaggression, that's not what they call it, but when they experience a microaggression from a patient or a family member and they go to their supervisor, the supervisor just says, oh yeah, it goes to the territory. That's not the right answer. They do not feel support. But what that speaks to is the supervisors have experienced it and they haven't been able to deal with it adequately. And our learners are experiencing it and not receiving the support that they need, part of what occurs with burnout. And so in a survey of 7,400 surgery residents from 262 programs, 32 reported discrimination based on their gender, 17 based upon their race, and 30% reported verbal or physical abuse, and 10% reported sexual harassment. Rates of all treatment measures were higher among women. 65% of women who were surgical residents in this study reported gender discrimination, and almost 20%, reported sexual harassment. Patients and family members were the most frequent sources of gender discrimination. 43% of the gender discrimination that the residents experienced came from patients and their families, and 47% of the racial discrimination came from family members. Look at the next slide. Attending surgeons were the most frequent sources of sexual harassment and abuse that the residents experienced. Proportion of residents reporting mistreatment varied across, here's a different point, but that first point, like, okay, reminded me of grad school. Anyway, proportions of residents reporting mistreatment vary considerably. Some people said 0, and some people said 66, almost 67% for verbal abuse. Burnout symptoms were reported by that number of 38.5% of residents, and 4.5 reported having had suicidal ideation. This next point I think is interesting from this study. Residents who reported exposure to discrimination, abuse, or harassment at least a few times per month were more likely to have symptoms of burnout and suicidal thoughts. Not only is it the occurrence, it's the frequency. It's the frequency. Let's look at the experiences of the LGBTQ plus residents. Microaggressions are in this in another study were very common, with attending surgeons being the most common perpetrator overall. I think this is an interesting study. 69, almost 7,000 residents completed the survey. 4.8 were LGBTQ plus, 95 were not. Discrimination was reported among 59% of the LGBTQ plus residents versus 42% who were not. Sexual harassment was 47.5% among the LGBTQ plus residents compared to 29%, and you see the bullying numbers there. Again, the source. Compared with non-LGBTQ plus men, the LGBTQ residents were more likely to report than the non-population. Both groups reported similar perceptions of the learning environment, career satisfaction, but the LGBTQ plus had more considerations for suicide. Well, when we talk about where does this come from, we often hear about implicit bias. And everybody knows what implicit bias is. Supposedly it's unconscious. I always question that. But in any event, it's pervasive. Everybody, it's not just BIPOC folk, everybody experiences implicit bias. Rebecca talked about a male being tall. You can look at someone who wears glasses and somebody would think, oh yeah, they must be smart or they read a lot, whatever. We see a quality of a person, an attribute of a person, and we assume who they are. So that's implicit bias, and everyone possesses, it's pervasive. What I am reassured by is the second characteristic. It can be unlearned, but you have to be very aware when it's happening. So if a new faculty member of color gets her first grant that she ever submitted, an R01, and she gets it funded, that little voice will go, well, how did she do that? Cut that voice off. Just go, congratulations, and mean it. If you are expecting that a student of color is in a slot that because they were an athlete, just cut that little voice off. You have to be aware when you are going down that path and talk yourself out of it, because everybody will say, that's not who I am. Microaggressions go against what we think are our core beliefs, and they do. We don't see ourselves as racist. We don't see ourselves as microaggressors, but very often we display those traits. So that's another thing. Follow our core beliefs. And Scientific American in 2018, they said college professors are 26% more likely to respond to a student's email from Brad versus Lamar. Thought that was interesting. And so our biases affect many things in academic and clinical settings: our perception, our attitudes, our behaviors. That bottom row is interesting. Our attention. What aspects of a person do we pay attention to? Their skin color, their hair, their height? What do we pay attention to? Our listening skills. You can see this in the clinical setting, in the academic setting. How much do we actively listen to what people say? When we hear and read about maternal morbidity and mortality, those who survive it were saying, I didn't feel right. I was trying to tell the doctor, this isn't right, and the doctor not listening to me. That happens all the time. My grandson had broken his hand, and I think he was 5 or 6. And he had gotten the cast on, and we were going to get it removed. And he kept saying, "I'm being burned." And the physician said, "No, you're not. You're just feeling some heat." We got home, there were 3 burn marks on my baby's arm. I cried because, he was being burned, but again, not being listened to. A little thing, that big old saw, but so many instances in maternal morbidity and mortality talk about not being listened to. Women who are having gynecological not being listened to. There are times when the medication is not working and you're saying, this medication is making me really sick. In some instances, they'll change. In some instances, well, just continue for a little while. Let's see how you feel later on. Not being listened to. And I am so interested in our micro affirmations. How much or how little we comfort and support. If it's a female, maybe we'll just give her a hug. If it's a big man, you're going, why is that man crying? I mean, it's amazing who we will support and who we will comfort and who we will not. That Anderson is not me in terms of the author. So there are some harmful effects of microaggressions, and all of us know this. The Institute of Medicine has looked at this, and one of the solutions is, well, we need to recruit more people of color into healthcare. Absolutely. And this was before that was that baby mismatch. You feel more comfortable with someone from your what you're familiar with. Again, here I go. Born in 1949 in a segregated South. So every physician I'd ever had was Black. And so I got to Boston. Even when I went to Hampton, my dentist was Black. So I got to Boston for grad school, and I wanted to go to a gynecologist. And I asked, a Black doctor, to some Black folk in Roxbury where I was doing my clinical work. And I kid you not, they said, "You want to go to a Black doctor?" I thought, well, yeah. So can you imagine my experience going to my very first gynecological visit and the doctor was white? I was so freaking uncomfortable because I never had been around a white doctor. I'd only had Black doctors who had been trained by Charles Drew, who had come from Howard, because I'm in North Carolina. A few had come from Meharry. That's all I knew. And so you feel more comfortable. Now I realize I really like female physicians, and that's all I will have. And so you all know the IAT, that's the implicit association test. It's online, you can take it, and it will suggest how biased you are. And I tell you, it's shocking. It is shocking. So, but look at that second bullet. So there were 287 residents in Boston and Atlanta, and they were administered the IAT. And so they were looking at implicit bias favoring white patients and Black patients. And so their thought was that, what they found was that the folk favored white patients, and there was this unconscious perception of Black patients as being less cooperative. Well, there's not a good history there. There's a lack of trust for lots of folk. But the likelihood of not administering, and what is that therapy? I have no idea. Didn't have time to look it up. The that thing. Okay, what is it? Thank you, blood clot buster. The likelihood of not administering that to Black patients increased as their pro-white scores increased. An inverse correlation. Very, very telling. So allyship. We recognize that individuals from underrepresented groups are at risk for discrimination and microaggressions. And then when there is intersectionality, as we always know, it's just compounded. So if you've got race and ethnicity, plus gender identity, plus LGBTQ plus, you can imagine what your world is like. And so in our healthcare disciplines, we realize that there also, when we're looking at students, we are looking at patients. There are not a lot of BIPOC faculty in our academic health centers. When we look at administrators, there are not a lot there. And so we need some allies. We need some allies. Another reason we need allies is when you look at the literature about what a microaggressee should do when having experienced a microaggression, it just presents the notion that you got to fix this yourself. Very often you do have to fix it yourself. But we need allies. It gets very lonely trying to fix this yourself. Figure out, should I respond, should I not respond? So the fact that BIPOC people are not highly present in these circles, in these contexts, we need allies. Underrepresented faculty and students cannot make change without allies. They don't have the privilege. A Black physician is upset because a patient refuses care from them due to their race. The white colleague says, well, he's never been rude to me, so that's a double microaggression. The family and then the white colleague. And an ally would inform the patient that, you know, we have a lot of providers on our teams and you must work with everyone. The ally is actively involved. A Latinx faculty member is released from a committee because that person is always talking about race and culture, the committee people feel. An ally would refuse to serve on that committee. An ally would engage in difficult conversations, another typo, regarding how does one get appointed and then dismissed from a committee? Okay. And so why does allyship matter? And it's pretty self-explanatory. Allies and bystanders are very different. Bystanders observe, and we tell bystanders to be upstanders, and you should respond. Allies are different from bystanders. They see that this is systemic. They see that this is structural, and allies want to go to the source of the problem. And so silence signals complicity. Allies will shift the burden. They will take it on. They look at culture changes. They do that bystander training, but it goes a lot more in depth. And so let's look at this. They recognize that microaggressions are harmful. They name it. They use their positional power. That's the difference between a bystander and an ally. Your friend can be a bystander and an upstander, and I hope so. But an administrator needs to be the ally. A professor needs to be the ally because you have to have positional power. And they put the person who's being harmed at center. And then there's some more things. I'm trying to move through this. Okay, let's go to macroaggressions. Macro is that systemic, that structural bias. We've all heard about redlining. That's an example of macro. We've learned that Black soldiers returning from World War II, if they were in the South, did not have much access to the GI Bill, which was so awful because we know the GI Bill built the white middle class. And then it was 50 years later when there's all in the news, oh, there's a rise in the Black middle class. Well, it took us 50 more years because we didn't have the GI Bill to lift us up to if you lived in the South, because the states administered the GI Bill. So those are examples of macroaggressions. They're structural and they are systemic microaggressions. They're powerful, absolutely powerful. And so here's some macroaggressions in healthcare. We all know the Tuskegee study. That was 40 years of awful treatment. In 1932, 399 men with syphilis and 201 without were misled with promises of treatment for blood. They were not treated. from 43 to 47, but they were told they were being treated. They were not treated. From 47 to 42 to 47, they knew that syphilis was the preferred treatment, but these subjects were not given the the penicillin. In 1969, the CDC reaffirms the need to continue the study despite the ethical concerns. The story was broken in 1972. It had been 40 years this study was going on. And it was not disclosed until 1972. In 1973, survivors began to get benefits. In 74, there was a $10 million settlement. In 1997, President Clinton issued an apology. And in 2004, the last original subject died. Lots of people point to the Tuskegee study for saying that's why Blacks don't trust healthcare. That's just one reason. There are many more, but this is the most famous. This is the one that brought about informed consent. This is the one that really brought about IRBs. And so we've got some of this same, oh yeah, this is the slide I wanted to remove because you've seen it before. So, but macroaggressions in breast cancer. Black women who live in low socioeconomic status neighborhoods are more likely to develop an aggressive subtype of breast cancer called estrogen receptor negative. I don't know if that's what the mama has on Beyond the Gates, but I watch it every day. And there is, and one of the characters has breast cancer, and she's Black, and you go through this journey with her. So Black women have this estrogen receptor negative. In 2014, a landmark study revealed Black women who have had more than one child, but who never breastfed, were more likely to develop ER negative breast cancer, and the risk increased with each additional birth. So why aren't the moms breastfeeding? It may be a preference, but it may be a lack of opportunity. If you are working the jobs that many Black women work, they can't breastfeed, they can't pump the milk, they don't have long enough maternity leaves, so there may not be the opportunity to do this. Along with they may not prefer to do that. Cesarean sections, again, macro, because it just seems to be structural that neuroaxial blocks are preferred, but more Black and Hispanic women are not given that option, but are given general anesthesia. So the racial disparities in health and healthcare have been documented for generations, and they're saying it costs over $1 trillion. And so what we're looking at is, we're looking at the zip codes and all of that, but many people are saying there's something about being poor, there's something about being Black, being subjected to these microaggressions every day. So one observation is becoming increasingly clear: racism and systemic stressors may be stronger than your individual choices, lifestyle, or your genetic differences. The psychological trauma may be related to cortisol increase, and there's been this occurring in the literature a lot more. But when it's increased, you've got elevated blood pressure, you've got memory problems, and you have other conditions. So macroaggressions in academia. 2004, I remember when this report came out because I thought it was wonderful. Minorities in health professions, we're missing, we're MIA. But we understand that we need more people of color in our profession, so that bottom dot says healthcare providers and their population should be a match. So the recruitment is so important of healthcare providers of color, but it's challenging. The first column gives you, let me see, where am I? Okay, I'm basically okay, I think. Those are the US numbers by the Census Bureau, what they published in 2024. So what we see is that physicians, in terms of the presence of white physicians, it matches the national demographics. All other professions that I have up here 80% of nurses are white compared to being 58% of the population. Um, my profession, speech language pathology, we're one of the whitest professions that there is. 82% of speech language pathologists are white. And as you go down the chart there, you see 14% blacks in the population. Going across, I don't see 14%. Hispanics, 20%. Going across, I don't see 20%. We're underrepresented. Asians are overrepresented in lots of instances, and you see the numbers there. I just thought this was interesting. Nationally, Hispanic, Black, um, uh, Alaska Native and American Indians, and Native Hawaiians and other Pacific Islanders are underrepresented among physicians. And I just thought these other three bullets were really interesting in that Hispanic populations are most underrepresented in the West, in the Southwest. Goes against my stereotype. The Black population among physicians is most underrepresented among physicians in the Southeast. Vicki. It's very important. Thank you, Vicki. The same for Hispanics as well, but for Asians, absolutely, absolutely. Thank you for raising that. Oh, yes, that's what Vicki's speaking to, the population. I'm, this is using US census and categories, so that's what's here. And we know how deficient that is. It's very, right, yeah, yes, absolutely.
Well, it covers huge people here. I mean, it's almost insane to think about.
Mm-hmm.
Yeah, exactly.
Yeah. So thank you so much for bringing that up. Um, okay. White population is overrepresented in the Midwest. Thought that was interesting. And so let me share this with you because I think it's very, very interesting. Remember, we need more people of color. And so the number of first year enrollees in US medical schools rose by 0.8% the 24-25 academic year. 24-25, there were gains in applicants. So we got increase in enrollees. Let's look at applicants. There were gains in applicants among blacks, up 2.8%, Hispanics up 2.2, and among American natives and Alaska natives, I left off the number, but there were increases. This is applicants. Enrollees dropped in the double digits. Enrollees is different from applicants. Black matriculants, those are the people that enrolled, declined 11.6%. Hispanics, those who enrolled in 24-25 compared to 2023, declined 10%. American natives or Alaska natives declined 22%. Native Hawaiian and other Pacific Islanders declined 4%. Applications went up, but being accepted and enrolled went down. So we need allies because this is a huge problem. Beginning July 1, in nursing and all these other disciplines, the Secretary of the U.S. Department of Education is halving the student um, awards, student funding, is halving it. The wrestling lady is halving our what students can apply for funding in all disciplines, but in most disciplines, not in medicine. All the associations are really upset about it. And so we need for inclusiveness, we need a culture of openness. Let me go back. We need some institutional policies, and we need to teach microaggressions. Microaggressions should be on the syllabus in all of our courses. And we need small group critical conversations. And so there's an example of this, and here's there, and there's that. We need more folk and people of color in our clinical trials, because this is what happens. There's equity impact in clinical trials. And here's some wonderful reasons about addressing structural barriers when you've got more people of color in clinical trials. You build trust with the community with clinical trials. You advance equity in research with clinical trials. You generate evidence that will inform policy with clinical trials. For nearly 30 years, BU has led the largest and longest running study of Black women's health, shining a light on the disparities. And this lady said, when I first heard about the Black Women's Health Study, I said, thank goodness, someone finally heard me. And so I've got one more point to bring up that I didn't know about, the fourth bullet. An elevated risk of stroke, this is coming from the BU study, among participants who had a history of preeclampsia when they were pregnant, and even 20 years after delivering their babies. If they had preeclampsia, they have a higher risk of stroke. These are some differences that are coming from that study. I have one more thing to say, and that is macro interventions for learners. Simulation can be so effective. Train your standardized patients and let them be macroaggressors. Train your students, let them be macroaggressors. Role play this. Simulation can be a wonderful way of looking at it happens and what do you do when it happens. And that's the end of my talk. Oh, I got 1 minute. I'm gonna do this really fast. Okay, I'm sorry, but I want to do this. Restorative reckoning. I want to look at the ANA. From 1916 to 1964, the American Nursing Association, I did this word twice, but it's systematically and systemically excluded Black nurses. And then, and so then there became a Black Nursing Association. And the president of that, the National Association of Colored Graduate Nurses, president was going to meet with the president of the ANA, that's Julia, and they were going to New Orleans. And so Estelle could not go in because she had to go in the service entrance. And so she said, can we move the meeting? But Julia said, I'll go in the back door with you. And Estelle said, I don't think so. So they didn't have the meeting. And so, but President Osborne was the first Black nurse to earn a master's degree and became the first nurse ever elected to the ANA board in 1948, and nobody else until 1970. And so there are the National Black Nursing Association, the National Hispanic Association. So today the ANA says we apologize for past harms. We are on a journey of reckoning and reconciliation, forgiveness and healing. This journey will take some time, but it's one that the ANA, that's my typo, is fully committed to. And we invite others. They're talking about we need allies to strengthen who we are as a professional association in the broader nursing profession through inclusion, diversity, and equity. And so my dot is there. We all must adopt this covenant to be inclusive and just in our professions. We've got to apologize for what has happened, and both sides to come together and talk about what has happened in order to move forward. Thank you very much.
Thank you so much, Dean Noma. I don't know the people in the room. I can't see them, but I hope we can clap for Dean. And there are some laughs on the screen for you. Everybody is showing their laughs. Thank you so much. I know we have we are on point, exactly on time, but maybe we can have some 1 or 2 questions in the room.
If you've got to leave, leave. There's one person raising his hand to ask a question, Sefacor, and you didn't even see him.
Okay, thank you.
We're going to get that question.
Okay, thank you.
But if you have to leave, please leave.
Yes.
Can you say it? Can you
please use the
Yeah, he's got it.
The mic.
But if you hear rustling, it's people have got to go. And I'm so sorry I talked too long. Go ahead.
Two comments. Wonderful talk. How do you like frame that in that it's 2026 and everything that's happening in like the political realm in our country? That's one. And number two was the YMCA just did a movie called Gone Guys or Gone
Yeah,
Boys.
just saw that last
And-
Saturday.
And I really thought that was really powerful. And I was wondering what you thought about that, you know, like in terms of your talk about the
Oh,
diseases of
absolutely.
despair that are affecting, you know, these men.
You know, the author of Boys and Men was here at University of Vermont talking about the underachievement of males today, and it's a real problem. It's a huge problem. And then how do we look at all of this in 2026? Allyship, and that's what we're seeing. Anyway, I was going to say something. I don't want to record it. Anyway, what we see is a great deal of allyship, and I think that's the way we will get through this. But being aware of where we've come from, so we do not repeat it. That's what I would say. Thank you very much. Thank you, C.A.R.E.
Thank you so much. Is there any question in the room again, please?
I'm so sorry. What?
Any question in the room? Any hand?
No, everyone's got to go, C.A.R.E. I talked too long.
Okay. Once again, thank you so much. Thank you to our interpreter. And I wish you all a very fruitful rest of your day. Thank you.
Thank you. Thank you, C.A.R.E.